Hi guys, Dr. Crafts here, narrating a lecture for you on tissue repair. Here's some objectives for you. Starting to get a little bit more involved with the objectives, so there's a couple slides of them here. Let me know if anything doesn't make sense or if you have questions on anything, but I think they're pretty extensive. So if you know these things, I think you should be good. So here's our general outline. We're going to start with some definitions. It's obvious pretty much, I guess, what this lecture is about, but there's a couple terms that you need to know specific definitions for, so we'll talk about that. We'll talk about the three different types of tissues in our body according to their proliferative capacity. That's something that's important because you'll need to know how to determine whether a wound is going to scar up or whether it's going to regenerate or not. Then we'll talk about the two pathways by which we repair damage in our bodies. One is regeneration and one is scarring. And then we'll talk a little bit about some specifics that you need to know about for skin wounds in particular, and then we'll wrap up with just some abnormalities. So let's get started with some definitions. So for this lecture, we're talking about just the broad idea of this lecture is how do we heal damage in our bodies? And we obviously have to have ways to fix damage to our bodily tissues when it occurs, otherwise we die. So that's kind of the broad topic. And we're talking kind of about wounds more so than any other type of injury, but really there's all kinds of injuries that we can sustain. I mean, we can get wounds like from a knife or from a scalpel or whatever, but we can also get wounds internally from things like chronic inflammation. So stomach ulcers are an example of that. Stomach ulcers are caused by a bug called Helicobacter in most cases, which really it's weird because it doesn't really invade the stomach mucosa. You'd think it would, but it doesn't. It just sits on top and it stimulates our own immune system to react against it. And so it's really the chronic inflammation that does the damage to our tissues that causes stomach ulcers. So chronic inflammation is another pathway for tissue injury. There's also things like ischemia and necrosis. So if you lose blood supply to a part of an organ, like your heart, for example, the tissue will die and become necrotic, and you'll have to have a way to replace that or fix the damage. So all kinds of injuries that we get, and we have to have ways to repair those injuries. So that's what we're talking about in this lecture. And here's an official definition of tissue repair. You can define it this way: the restoration of tissue architecture and function after an injury. I kind of like it, but then again I kind of don't, because you can't, in most cases, if you really mess up the architecture of a tissue, if you have a deep stab wound or if you kill off a bunch of cells, you can't really restore the normal architecture in most cases, and that's where scarring comes in. So when you're repairing something, you try to restore the architecture as well as you can, and you try to bring the tissue back to its normal function. So I guess the process just involves those two different things. You're restoring architecture and function. There's two processes that are involved in tissue repair. One is regeneration, and the other is scarring. So regeneration is a full restoration to normal. So it doesn't happen actually super often on a very large scale in humans. Like amphibians, if you cut off an arm of an amphibian, it'll grow the arm back. And we don't have that capability, but we do have some ways of regenerating tissues on a kind of a smaller scale. We'll talk about those. So it's just this part of the process is just regenerating tissues, bringing them back to their normal state. The other process, connective tissue deposition, is used when you can't fully regenerate a tissue. And in this process, you lay down collagen and make a scar, and that kind of fills in the gaps where you're missing tissue, and it sort of knits the tissue back together, so at least you have a functional, intact piece of tissue. So most wounds of any substantial size really involve both of these processes. There's some regeneration and some scarring. So we'll talk about them as separate processes, but in many cases there's a little bit of both involved in healing a wound. So here's a diagram from our book showing normal tissue on the top, and they're showing us an epithelial type of tissue where there's cells lined up next to each other sitting on top of a basement membrane. Looks like some sort of simple cuboidal epithelium there. And then they're showing us two different injuries: a mild superficial injury on the left that just damages some of the epithelial cells, but otherwise everything's intact, basement membrane's intact, everything underneath is intact. And then a severe injury on the right where you have damage to the epithelium, but also to the underlying structures, basement membrane and the tissue underneath. So with that mild superficial injury in epithelial tissues, you can regenerate those cells. You can grow them back, and it basically looks like nothing ever happened. And that's true regeneration. Just bringing the tissue back to its normal state, no evidence that anything ever happened. And that can occur, and it does occur actually frequently in certain types of tissues in our bodies, especially epithelium. But even in tissues where regeneration is possible, if the injury is severe enough, like they're showing here, where you're damaging the underlying structure, you can't really recover from that. You can't really regenerate entirely if you have a severe injury. So that's when the other process, scar formation or connective tissue deposition, comes in. And that's just something you have to do if the injury is severe enough. You regenerate a little bit, if you grow new epithelial cells maybe, but you got to put in some scar tissue to kind of knit the tissue back to normal. So just a cartoon showing these two different pathways that we'll be talking about: regeneration and scar formation. So let's talk about 3 different types of tissues that we have in our body, just according to their proliferative capacities. I mean, obviously there's tons of different kinds of tissues if you're looking at other parameters like, histologic type, epithelium versus connective tissue or whatever. But if we're just looking at the ability of tissues to proliferate, there's 3 different groups of tissues, and that's what we're looking at here. So labile tissues are the first type of tissue, and they're composed of cells that are constantly being sloughed off or killed. So they're tissues like skin, any epithelial lining really, the lining of your GI tract, lining of your lungs. Bone marrow is another one. It's not epithelium, but you're constantly losing your red cells, white cells, and platelets, and so you have to replace them. So these are the main types of tissues that fall into this category. So you're constantly losing skin cells and blood cells. So of course, these tissues have to have some way of replacing those lost cells. And the replacement happens in 2 ways. A big part of it comes from stem cells. So these tissues have a big pool of stem cells that are just sitting there and waiting, and constantly dividing and providing new cells that can mature into the mature cells of that particular tissue. And stem cells live pretty much forever, so that's great. So that's one part of it. The other way of replacing the lost cells is from proliferation of mature cells. And not all cells in labile tissues have this capacity, but some do. So even in your skin, there's some of the squamous cells that make up your skin have the capacity to proliferate and divide. Even though they're technically mature, they look mature, but they still have that capability. So proliferation is pretty robust in these tissues, and they're said to be continuously proliferating because they really are. You're constantly losing cells, so you constantly have to replace them. So this is the type of tissue of the three that we're going to talk about that is the best at regenerating after injury. It doesn't always completely regenerate, though. So we're going to talk about scarring in a little bit, but I just want to put this idea in your head that if you get a severe enough injury to labile tissues, one that disrupts the underlying extracellular matrix, the underlying architecture of that tissue, you're going to have a scar. So like a really bad skin wound, deep cut to the skin, for example, you're going to have some regeneration, but you're also going to have to fix that wound with some scarring too. So regeneration depends on a couple things. It depends on the type of tissue, but also the extent of the wound. And we'll talk more about that in a minute. Here's some stem cells in the GI epithelium. This is just a little crypt that we're looking at here, a portion of a crypt in cartoon form. And these are the stem cells in blue. And so all labile tissues have a pretty big pool of stem cells. And the point of that is to provide a constant source of renewal for the cells that are being lost. Stable tissues, next type of tissue, sometimes called quiescent tissues. These are tissues that they probably have some stem cells, but not a ton. And their mature cells typically don't proliferate. They just sort of mature and sit there and don't undergo constant proliferation. But if you get an injury in these tissues, the mature cells can be encouraged or coaxed back into the cell cycle. So they do have this capacity to proliferate. It's fairly minimal in most cases, but it's there. So in stable tissues, you can have some regenerative activity after an injury. It's not typically as robust as you'd see in a labile tissue, but there is some ability to regenerate. So it's kind of a step down in terms of ability to regenerate from labile tissues. And some examples here: liver, kidney, pancreas. These are all composed of parenchymal cells that typically are just sitting there, not dividing, but you can encourage them to undergo proliferation after an injury. And then the last group, you can kind of see where we're going here, permanent tissues. This is a type of tissue where the cells just can't proliferate. They can't be encouraged back into the cell cycle. They're at an end stage of maturity where they can't undergo any proliferation. No amount of coaxing is gonna do it. And there might be some stem cells in these tissues. There are some stem cells in these tissues, but they're small in number, and they just don't have enough regenerative capacity to really replace tissues that are cells that have been damaged. So in the brain and in the heart, neurons in the brain and cardiac myocytes in the heart, they really can't, the cells themselves can't undergo proliferation. They can't be brought back into the cell cycle. And then the stem cells that are there really aren't, they don't have enough capability to proliferate or to provide new cells to really respond in any way after injury. So any injury to these tissues, these permanent tissues, will result in some scarring, even if it's a small injury. So myocardial infarction in the heart, tissue death in the heart, no matter how small, is always going to be repaired by a scar. And same thing in the brain. You lose neurons, and you're not going to regenerate that tissue. You're going to end up with a healing response that's kind of like scarring. So here's the cell cycle, just to kind of point out to you where each of these types of tissues, where those cells live in the cell cycle. So starting at the top, continuously dividing or continuously cycling cells. The more common name for this is labile cells or labile tissues, these are composed of cells that are constantly undergoing regeneration, even, just from daily wear and tear. And so there's stem cells in there that are constantly within the cell cycle. They're just going around and around all the time and providing new cells. And even the mature cells themselves can often and do often provide some proliferative capacity as well. So in this type of tissue, the cells are just constantly going around the cell cycle, or many of them are. In stable tissues or quiescent tissues, like the liver, kidney, pancreas, these cells normally aren't in the cell cycle. They are mature and they are in a state or a phase of the cell cycle called G0. It's not really a phase of the cell cycle itself, but it's a resting phase that's outside the cell cycle. And so they're just sitting there in G0. But if you have an injury, you can pull these cells back into the cell cycle, and they do have some limited capacity for proliferation. So that's where these cells, these tissue cells, sit with respect to the cell cycle in a phase called G0 that allows them to be recruited back in if necessary. And then finally, permanent cells like neurons, cardiac, muscle cells. These cells just sit outside the cell cycle, and there's no ability for those cells to return to the cell cycle. So they're not even given a phase that corresponds to the cell cycle. They're just outside the cell cycle completely. So let's talk about these two different pathways for tissue repair. And the first one is regeneration. So regeneration is this restoration of the tissue back to its normal state. No scarring, just restoration back to normal. And regeneration, the ability of a wound or an injury to undergo regeneration is going to depend in large part on what type of tissue the wound is occurring in. So if it's occurring in a labile tissue, you got a good chance of regeneration, especially if it's a small wound. Same with stable tissues. You do have some capacity of regenerating stable tissues. But if it's a permanent tissue that your wound is in, you're not going to have any regeneration at all. So this just is kind of a reiteration of what we just said on the previous slides. The tissue type is going to dictate, at least in large part, whether you can undergo regeneration or not. The other factor is the extent of the injury, and we'll talk about this in a little bit when we get to scarring. So regeneration happens all the time on a minor scale in labile tissues. So you're constantly losing skin cells and constantly replacing them with in this process, not with scarring, but just by regenerating. And then in stable tissues, there is some regenerative capacity. In the kidneys, for example, if you take out one kidney, the other kidney is going to get bigger, and it undergoes two different processes. And these are terms that you learned in the first lecture, the cell injury lecture. Hypertrophy means cells get bigger, and hyperplasia means cells get more numerous. So those are terms that you should know the definitions of pretty readily, because they'll kind of keep popping up here and there when we talk about pathology. So when you remove one kidney, the other one undergoes hypertrophy, the cells get bigger, and hyperplasia, the cells proliferate. And this really isn't exactly regeneration. Real regeneration would be like you grow back the kidney you took out. And we don't have the capacity to do that or the capability to do that, but we can make the other kidney bigger. So it's kind of falls under regeneration. It's certainly not scarring. So it it's a little bit of a stretch, but it kind of falls under the title of regeneration, I guess. And the liver actually has a pretty strong regenerative capacity. If you take out half of the liver, the rest of the liver will get bigger. So the liver actually doesn't grow back to its normal structure exactly, go back the same exact lobe structure. So it kind of looks like a lumpy, kind of enlarged mass, but it does grow back. And we'll look at that on the next slide. So that's pretty cool. The liver actually has a pretty good regenerative, or pretty strong regenerative capacity, at least compared to other stable tissues. And then permanent tissues, there's no regenerative capacity whatsoever. So here's a CT from somebody who donated a portion of their liver to somebody else, and it's a CT before and after the donation. So on the top, this is the orientation is the patient is lying on their back and the feet are sticking out towards us and the head is pointing away from us. So we're just kind of looking up at the liver. So the white outline on the top drawing, A, or the top CT, outlines the right liver lobe, and that's what's going to be taken out. And you can see the rest of the liver there too. It's just not outlined in white, but it's adjacent. So the left lobe is still sitting there. And then if you look at the lower drawing, here's where the right lobe was. It's now gone. But you can see that the remaining liver has grown bigger. And it hasn't exactly grown back in its normal structure. So it hasn't like grown a new right lobe. But still, it's pretty amazing. The left lobe is a lot bigger. And if you were to look at the mass of the liver now and compare it to the mass of the liver before the resection, they'd probably be pretty much the same. So the left lobe is enlarged to provide the same amount of functional tissue that the person had before. It's really, it's kind of hard to believe. And what's even more remarkable is this timeline, 1 week after resection, and the liver has grown back. It's just phenomenal. And this is from our book, which is a really reputable source. So this is actually true. It seems like I'm exaggerating or making it up, but I'm not. It's actually true. So let's look at scarring, and there's quite a bit more to talk about in scarring because there's different steps that you have to undertake as you make a scar, and we'll just spend a little more time on it because with these exceptions that we talked about, mild injury to labile tissues and stable tissues, you really do have to make a scar with many of the types of tissue damage you get in your body. So we'll spend a little more time on this. So when do you make a scar? Well, you make a scar when full regeneration isn't possible. And so one of the objectives is asking you, one of the learning objectives at the beginning is asking you to figure out if somebody gives you an example of a wound, how do you know whether it's going to undergo regeneration or scarring? And the two things you need to know are A, what type of tissue is the wound in, and then B, what's the extent of the damage to the extracellular matrix. So regeneration is possible only in labile tissues and stable tissues. So the type of tissue matters. If it's a permanent tissue, regeneration is absolutely not possible. And then even in labile and stable tissues, the extent of the damage to the underlying extracellular matrix is another important factor. So mild skin wounds where you just kind of abrade a little bit of the surface epithelium and you leave the underlying extracellular matrix alone, the basement membrane's intact and all this, the connective tissue underneath the basement membrane, everything's intact, then you can regenerate. But if you get a big old stab wound where, you've damaged not just the epithelium, but the basement membrane and you've cut out a chunk of tissue in the dermis, well, that's too much damage to the extracellular matrix to undergo complete regeneration. Same thing with the liver and the kidney. And the examples we gave actually of regeneration on the previous slide are, they're kind of regeneration, but they're not. They're more like compensatory growth. You can have some real regeneration, though, in liver if you don't damage the extracellular matrix at all. So if you have a toxic exposure and you just damage the hepatocytes, but all the underlying extracellular matrix, the little basement membranes that they sit on, and all the structures of the hepatic globule, if that is all intact, you can regenerate in the liver. So even in stable tissues, if you just have minor tissue damage, but the underlying matrix is intact, you can undergo regeneration. So these are just the two factors you need to know: the type of tissue and then the extent of the extracellular matrix damage. If there's no damage at all to the underlying matrix, then you can undergo regeneration. But if you've damaged that underlying matrix significantly enough, you're going to end up with some scarring. Okay, so I hope that's clear. There's several steps to scarring that we're going to look at on the next slide. And you have to do a bunch of things. You got to create new blood vessels, first of all. That's called angiogenesis. You have to create new blood vessels into the damaged area to bring new cells to the area. Fibroblasts actually come through the blood as well as through the existing tissue. You've got to bring nutrition. You've got to carry oxygen into the tissue. So blood vessels, that's pretty important. And then you've got to lay down some collagen. And the collagen that you lay down is made by fibroblasts, which are these connective tissue cells that have all these different capabilities to make things like collagen and elastin. Here we're just talking about collagen. So that's the second big step, is laying down collagen. And then after you've done that, then you undergo a process called remodeling, where you kind of chip away at that collagen and cut it down to its right size so that the scar is just right. You don't want a big old hunk of collagen interfering with tissue functions. So you kind of remodel it after you've laid it down so that it's just the right size to hold the wound together. So we're going to look at these steps now on this next slide. So here's the little diagram that's showing some of the steps involved in scar formation. So at the very top panel, you can see there's a bunch of cells, everything looks good. And then second panel down, there's some sort of injury to the tissue, and it looks like it's bad enough that it's really kind of disrupted the cells. Maybe there's some necrosis. They don't really tell us exactly, but some kind of injury that's really disrupted that tissue. So third panel down is showing us some inflammation, and that's the lecture that you guys talked about, or that you heard about from Dr. Reinertz. He talked about how when you get injured, you get first acute inflammation with neutrophils, and then chronic inflammation with macrophages and lymphocytes. And the point of that really is to take care of the offending agent if it's still present, if it's an infection, for example, but then also to get rid of dead tissue. So that's kind of what they're showing us here. There's some neutrophils, looks like, in there. Neutrophils have enzymes that really just kind of dissolve cells and substances. So neutrophils come in and kind of release their potent enzymes, and then they kind of take off, and then macrophages clean up the damage afterwards. So that's the third panel down. Fourth panel down, now we're starting to see some of this scar formation that we're talking about in this lecture. So formation of granulation tissue. This is really important, and I want to stress this a few times in this lecture to make sure that you guys know what this is. This is the substance that you use as a kind of a template when you're forming a scar. So granulation tissue is something that comes in, it fills in this area where the scar is going to be, and then it contains everything you need to make that scar. So let's look at the stuff that's in granulation tissue. There's three things. The first thing here is new blood vessels. You have to grow in new blood vessels into this area if you want to have any healing, because you need nutrients from the blood, and you need cells, inflammatory cells, even the fibroblasts that we're going to talk about in a second. They actually come through the blood, which is weird because you don't see them floating around, but apparently they come in the blood. oxygen, just everything that you need for healing comes in the blood. So they're showing us here some existing blood vessels that are kind of growing little sprouts into the damaged tissue, and that's exactly how it happens. Just these delicate little capillaries. Can't even really call them capillaries at the very beginning. They're just really fragile looking little blood vessels grow into the tissue. So new blood vessels is the first thing. Second thing is fibroblasts. And these are elongated cells that have a spindle shape. And when you hear that term spindle, it just means an elongated cell that has points at both ends like this. Fibroblasts make a lot of different things. We talked about them as kind of the main cell in connective tissue way back when we did histology. So they make collagen and elastic fibers. They make all kinds of stuff. Here we're more interested in the collagen. So the fibroblasts come in and they're going to start making collagen, which is going to turn into that scar. And then the last thing in granulation tissue is extracellular matrix, and it's just this loose stuff that you can see here. It's kind of depicted in pale blue. It's got stuff like glycosaminoglycans and growth factors and proteoglycans and all kinds of stuff. It's that portion of connective tissue that doesn't have cells in it. So we talked about that in histology too. There's hyaluronic acid in there and glycoproteins and all kinds of stuff. And that's really critical because it's kind of making this whole area kind of nice and juicy and moist, and it's also holding growth factors and cytokines and all kinds of stuff in place as these cells are doing their delicate kind of engineering of this space. So as this granulation tissue progresses and matures, the fibroblasts just make more and more collagen, and eventually the blood vessels, the new blood vessels that you've created, they kind of fade away. You don't really need them anymore because you're done healing. The inflammation is gone. Most of the extracellular matrix is gone too, and you're just left with this hunk of collagen. It's depicted here by these long, fibrous looking lines. And at the very end, after you're done making your scar, you undergo a process called remodeling where you kind of cut the scar down into the appropriate size. You don't want to have a big honking scar in your tissue because it can interfere with, tissue function. So you want to remodel it and cut it down to size. So you can kind of summarize this whole process in just 2 steps. The first thing is to make that granulation tissue, and then over time to turn that granulation tissue into a chunk of collagen. That's basically it. Here's granulation tissue. It doesn't look like much. It's called granulation tissue, by the way, because it's got kind of a granular appearance to it. It looks sort of pink and bumpy or granular. So if you've ever had a skin wound where you had a scab and you picked off the scab before it was really done fully healing underneath, you saw that pink, tender, kind of bumpy, granular looking tissue, really easily bleedable, or not bleedable, what's the word? Bleeds really easy. That's granulation tissue. So here's that stuff under the microscope. And it's got the 3 things we talked about on the last slide. So new blood vessels. And they're all over this slide. They're kind of hard to see because they don't have a real, firm wall to them. They're just kind of barely there. There's just look for red cells, and wherever there's a big clump of red cells, that's a new little blood vessel. There's endothelium surrounding them, but it's really, really delicate. It's hard to see. So new blood vessels carrying in the stuff you need for healing. And then fibroblasts. Fibroblasts are really hard to see. And I looked around in this slide and I really couldn't see hardly any, but because they just sort of blend in and they're just sort of boring looking. And so your eye just kind of glosses over them. But even after poring over it, I couldn't really see anything that I was convinced was a fibroblast. And that's often the case. So What you can see, though, in any granulation tissue, no matter what the age is collagen, the product of those fibroblasts. So you can see collagen in this particular specimen because it's stained with something called a trichrome stain, which stains collagen a blue color. Normally collagen would be stained kind of a pinkish color, but they stained this with blue just to make the collagen stand out more. So new blood vessels, fibroblasts, you can't really see the fibroblasts, so we're looking at collagen kind of as a surrogate here. And then the last thing is extracellular matrix, and that's just the clear stuff that's sitting in between the cells, the blood vessels and the collagen. Over time, the blood vessels kind of just sort of disappear. You can see some here, but they're less numerous, and eventually they're just going to fade away, and they're going to be replaced by collagen. And this is the same trichrome stain that was used on the previous slide, and it's just staining really blue because this is a later, a wound in its later stages of healing, when it's actually basically a scar. Eventually all the blood vessels will drop away, so this isn't quite totally mature, but it's mostly collagen. Granulation tissue is one of those words that you can mix up with other words pretty easily, and the one that you most commonly might mix it up with is granuloma. So granulation tissue is not the same thing as a granuloma, even though they have that gran prefix. A granuloma is something you see in a particular kind of chronic inflammation where you've got something that isn't really easily digestible. So this was also covered in the inflammation lecture. If you've got foreign body, for example, like talc or a stitch or something from surgery, or certain bacteria like the tuberculosis bug, Mycobacterium tuberculosis, got a really waxy coat. It's really hard to kill using our normal immune system methods. So any of those things can provoke the formation of a granuloma. The granuloma is just the body's reaction to any of these kind of indigestible substances. It's a round thing, and you can kind of see this round, sort of roundish structure here. This is the granuloma, and it's composed of macrophages. And most of the macrophages here are just normal macrophages. They're kind of bland looking. It's really sort of hard to even point to them and be really sure what you're looking at, but I've circled 3 that I'm pretty confident in. They have kind of these elongated, bland looking nuclei, and they're all over the place. Once you start seeing them, you can kind of point them out all over. You can also see in this particular granuloma some gigantic cells. These are called giant cells, and they're just fused macrophages. So a bunch of macrophages get together, fuse their cell membranes together and become a gigantic cell with a whole bunch of nuclei that's really powerful. So you don't see these in all granulomas, but you see them in some granulomas. So these are giant cells. Sometimes we call them foreign body giant cells when we know there's a foreign body. And then sometimes around the edges of a granuloma, you can see these little dark blue cells. These are lymphocytes. If you look closely, you can kind of see them all over the place. Little dark circular dots. I mean, this is really low power, but I think you can kind of tell that these are circular. They're just little round things, as opposed to the macrophages, which are elongated things. So you often will see a kind of a collar of lymphocytes around the edge of a granuloma. So this is a granuloma. It's really got nothing to do with granulation tissue. Let's look at skin wounds. There's a few things you need to know about skin wounds, some terminology, and then I'm going to give you just some examples. So in skin wounds, there's this kind of arcane language that we use, but everyone loves to ask about it, and it's pretty common sense. Once you understand what's going on, you can kind of come up with all the characteristics that each of these types of healing has on your own, really. But we need to talk about it just so you know that these terms exist and what they mean. So 2 types of healing. This is just in skin wounds. first intention and second intention healing. First intention healing is in little wounds where you can pull the edges together, like a paper cut or a sutured incision that's pretty small. Second intention healing is in larger wounds, but really any wound where you can't pull the edges together, where you've got open tissue that is going to need some extra work to heal up. So burns, ulcers, anything where the edges don't come together neatly, that would be second intention healing. So let's look at some of these characteristics on the next slide. So I've got small and large here. These are relative terms, obviously, but really the point is that first intention healing happens in wounds where you have edges that close, that you can approximate together. So either with sutures or just naturally the edges just sit close to each other. That's the whole thing. Usually that means a smaller wound, because once you get relatively large in your wounds, sound like a wound expert, I'm really not, but once you get to a larger size, the edges aren't going to hold together. Even if it's a big cut, a big gash, the edges aren't going to hold together on their own. So small-ish wounds that close easily, that's first intention healing. The type of wounds that heal with second intention are larger typically, and they're open. So anything where the edges aren't sitting next to each other. And you can all this stuff really makes sense. So in first intention healing, regeneration predominates over scarring. You're going to have some of both, probably, depending on the depth of the wound. I mean, I guess if it's a paper cut, you won't really have scarring. But really, if you can pull the edges together, the wound is going to heal with more scarring, more regeneration than scarring. If it's a first intention wound. Second intention healing, it's just sitting there open, right? You can't pull the edges together, so you're going to have more scarring. That's going to kind of be the predominating thing if you're just looking at those two types of healing. First intention healing is faster than second intention healing in general. If you're looking at similar sized wounds, faster. Second intention healing will be slower. And here's more stuff that just kind of makes sense. First intention healing, you can pull the edges together. The wounds are relatively small, so less scarring. Really, you have some inflammation, but pretty minimal. And there's really not a lot of risk. You're probably going to heal up pretty nicely without much chance of complications. Second intention healing, in general, larger wounds, you can't pull the edges together, so there's going to be more inflammation as you try to clean out this dead tissue, more scarring because you can't even pull the edges together, so of course you're going to have a scar knitting that wound together. And then it's sitting there open, right? It's an open wound, so chance of infection is going to be greater. Anytime you have an open wound, with the edges aren't closed up, it's going to be easier for bugs to just land on that wound and start proliferating. So I've got some examples here, but really you can think of them on your own. First intention healing, things that you can approximate the edges. So paper cuts, surgical incisions, especially smaller ones that are sutured. Periodontal flaps, I don't even want to know what that is, but apparently that's something where it's a flap of tissue that you kind of replace. Oh, sounds awful. So those would be first intention. Second intention healing, things like burns. These things will make more sense to you too, but gingivectomy sounds to me like you're taking out a part of the gum, and external bevel sounds like you're taking out a chunk. Extraction sockets, that's self-explanatory. So these are wounds where there's just a big gap that's going to have to be filled in as you heal. So let's look at some pictures just to make sure that that I've covered everything here. So here's first intention healing. First intention healing happens in kind of several stages, but you can kind of boil it down to three separate stages. So first thing about this wound to notice is that the edges are close together. So this is just a little cut into the skin It's made it down into the dermis, underlying the epidermis, so there's going to be some scarring, really, but it's still a smallish wound where the edges are close together. And we're going to look at a timeline here for first intention healing, and I'd like you to kind of stick this in the back of your mind. It's not going to hold for every single first intention wound, but it'll hold in general for most kind of smallish first intention wounds. And I think it's just important to know when these different stages happen. So this whole thing on the left here is kind of a rough timeline for first intention healing of small wounds. And I'd like you to kind of commit that to memory. So first thing that you do in the first 24 hours is you bring in a bunch of neutrophils. This is that acute inflammation that you talked about that you heard about in the inflammation lecture. Neutrophils come in and they are kind of killing off debris, infection, if there is any tissue that needs to be removed, cells that are dying that need to be gotten rid of. So the neutrophils are the first responders on the scene. There's a couple other things going on here too. You've got a clot, so you've stopped the blood. This cut has made it through a blood vessel, so you've stopped the bleeding and you made a scab. So that's all within the first 24 hours of a typical first intention wound. Next, over a period of a few days up to a week, that's when you start seeing granulation tissue. And granulation tissue, again, is this combination of new blood vessels, which you can kind of see here. There's a new capillary in this particular pane of the diagram. Fibroblasts, which are pointed out here, these little stellate cells, and then sort of a loose extracellular matrix. And it's not pointed out here, but it's everything in between the little cells and blood vessels here. So granulation tissue fills in that space within the first week. And then as the wound matures over time, over the next few weeks, those fibroblasts are going to make collagen and you're going to end up with a scar. And they've written fibrous union here. I don't know why they didn't just put scar, but it's just scar. So collagen forming a scar. So that happens over a period of weeks. Here's healing by second intention. So this is a wound where the edges are farther apart. They can't be pulled together. And you'll notice right away that this is going to be worse, right? And there's just going to be more inflammation here, more chance of infection. This is an open wound. I mean, there's a scab over the top, but it's still an open wound. And there's no timeline here because it's really hard. Healing by second intention happens in all range of sizes. They tend to be larger wounds than healing by first intention wounds. But there's no timeline here because it really doesn't make sense. I mean, if you have burns all over your body, that's going to take years to heal up. So no timeline to memorize on this side. So first stage is inflammation, those bunch of neutrophils here. Second stage is that granulation tissue, and notice how much more abundant it is here. You got to make a lot more granulation tissue for a second intention healing process because you've got more to heal. It's larger, edges are farther apart, you've got more work to do. So more granulation tissue here. And then at the end, over time, the fibroblasts are going to make collagen, and over time you're going to have a scar. And in second intention healing, you have something called wound contraction, and that's because the edges aren't close together from the very beginning. So you're going to have to contract that wound to make it smaller, kind of pull it together as you're knitting that collagen in place. So here's a picture of a second intention wound. This one is pretty small, actually. This is a foot. It's a pressure ulcer. Looks like it's right over the metatarsal, on the kind of the inside of the foot there. Might have rubbed against a shoe or something. So it's an open ulcer. The edges are spaced far apart. It's basically round, and then there's this stuff in the middle where the injury happened. So here's epithelium here, and then the stuff on the inside is the epithelium has been eroded. So an ulcer is an erosion into some sort of epithelial layer, either on the skin or in the GI tract or wherever. And if you look at it under the microscope, it kind of looks like you would expect it to look. There's some epithelium on each side here. Those are the epithelial edges that we saw on the previous picture. And then in the center here, there's no epithelium. It's been eroded, and that's just what an ulcer is. So it's this big area that's open, and you've got this wound now that you're going to have to fix. So over time in this wound, you're going to make granulation tissue, and here's the surface up here. There might be a little bit of epithelium growing up here, but I can't really see much for sure yet. This is from our book, and they say there's epithelium, but it's kind of hard to see. But anyway, that's the surface up there. And this is all granulation tissue here. You can see some blood vessels here, some new little blood vessels. Some look empty. That's just kind of an artifact of fixation. Some do have red cells in them. You can also see fibroblasts pretty well on this picture. These are elongated cells, kind of stellate or spindle-shaped. Stellate means star-shaped. That's another word we use for these cells that have kind of two or more little points to them. Spindle shape is elongated with 2 points. So you can kind of see these. They're kind of bland-looking cells. You wouldn't think they'd be up to much, but they're making collagen in here. And then the last feature is loose extracellular matrix. So that's granulation tissue. If you look close, though, there's other cells in here, and I tried to find some individual ones. I think these are pretty good. These are inflammatory cells. If you look closely, they look different than the fibroblasts that I circled in black. They're smaller, and they're pretty much perfectly round, whereas the fibroblasts have this sort of spindle shape with points on the ends. So these are inflammatory cells, and you can see a whole bunch of them up here. And these to me look mostly like lymphocytes. And I just want to make a point here. I know you looked at some pictures in the inflammation lecture, but this is just a good example of how you can kind of tell, even at low power, what kind of inflammation you're dealing with. And this is something you'll need to know when you get into oral path. You'll be asked, what's going on in the slide? And, well, they won't really grill you, but somebody might ask you that in a nice way. Much nicer than med school. Oh, and much nicer than pathology residency. Man, they were nasty. They give us a box of unknown slides, and then we'd have this conference that was horrific. But anyway, you might get asked at some point, what are these cells here? And you'd go, oh, they're inflammatory cells. Oh yeah, what type? And you'd go smartly, they look like chronic inflammatory cells, probably lymphocytes. So here's how you tell the difference. Lymphocytes look like this. They're just little dark blue round dots. And it looks almost like a rubber stamp, like somebody just went and just stamped them all over the section. They look pretty uniform. So these are lymphocytes. Neutrophils have a different look. They're kind of more messy looking. And I think maybe there are some neutrophils here too. But the ones that I circled in blue below, those are definitely lymphocytes. Neutrophils just have kind of more of a messy look, and that's because they have this nucleus that's segmented. And when you look at it in the blood, it looks like sausage links, but when you look at it in a section, in a histology section, it kind of looks like Mickey Mouse ears. In fact, it looks a lot like Mickey Mouse ears. And if we were to go on higher power, we might be able to find some of these down in this section. So I'll be pointing this out from time to time because I want to make sure that you sound and are super smart when you get to oral path. But that's the way you tell chronic inflammation from acute inflammation. Chronic inflammation, lymphocytes, little round dots, looks kind of neat. Acute inflammation is neutrophils, and they look more messy. So here's the last stage of that healing skin ulcer. The epithelium has regrown, and then there's been some granulation tissue here, but now there's also been some healing and maturation of that granulation tissue, and you can almost see how the tissue's been pulled together towards the center here. Wound has contracted to kind of make up for that space, to make the space between the edges a little bit smaller. I just want to say a couple things about wound strength because it's not entirely logical, at least it wasn't to me. So I made this little diagram. It's not super fancy, but I think it kind of gets the point across. So let's take a look at how a wound, a sutured wound, changes over time as it heals. So we're going to start with the wound right at the beginning, right at suture removal. And the strength at that point, the tensile strength of the skin, is about 10% of normal skin. So normal skin is 100%. You can see the y-axis on the right, or sorry, on the left. X-axis on the bottom is time. So 10% of normal skin strength, and that's kind of expected. I mean, you just took the sutures out. You know, if you pull on it too much, it's going to pull apart. So about 10% of normal. This is just kind of a generic, you know, for your average sutured wound. So what happens over time? Over the first month, the strength of the skin of the wound heals pretty quickly. I mean, it increases pretty quickly over the first month or so, goes up pretty dramatically. Then it kind of levels off, and around 3 months, it reaches basically the maximum strength that it's ever going to have. And that's only about 75%. And this is kind of, it kind of didn't make sense to me, or it isn't what I would have predicted, because, you know, collagen is really strong. So I would think that a scar, you know, that skin would be even stronger maybe than normal skin because it's got all that collagen in there, but it really isn't. So, and that continues over time. So for the rest of your life, it never really gets any stronger. So about 75%. So I think that's a reasonable thing to maybe stick in the back of your mind. I mean, you don't have to remember exactly, but just so you know that wounds never, healed wounds with a scar, they never reach the strength of normal skin, and they only reach about 75% of that. No matter how long you've had the scar over time, that's about it. I want to talk just briefly about some abnormalities that you can get in tissue repair. So what can go wrong in this process? Usually it works really well, but sometimes you don't make enough granulation tissue and you don't get enough scarring, and the wound just does not heal up properly. And there's some things that can interfere. The big one is infection. So if you get infection in a healing wound, a surgical wound or any wound, it's going to interfere. Infection is going to bring in more inflammatory cells, and you're going to have to get rid of the bugs, and there's going to be more tissue damage, and it's just going to prolong the process. So infection is one of the big reasons that you don't heal wounds in a normal span of time, that it takes longer to heal. Steroids will do this too. Steroids are actually anti-inflammatory, which sounds contradictory to what I just said, but if you are on big-time steroids, you're not going to be able to bring in enough inflammatory cells like macrophages to really direct this whole process. Macrophages come in as part of chronic inflammation, and they sort of give some signals that organize the whole scar formation, the whole healing process. So if you can't bring in enough macrophages, you're not going to make enough granulation tissue, or it's going to take you longer. You'll eventually maybe, but not as quickly. So steroids is another one. Diabetes is another one too. In diabetes, you've got poor blood circulation, especially to your extremities. You're more likely to get infections. It's just kind of a setup for slow, inadequate wound healing. So that's the first bullet point here. But there's a couple other things that I want to talk about where you have too much of one of the two processes, or too much of something going on. So too much scar tissue, that's called a keloid scar. If you have too much granulation tissue, that's something that's called proud flesh. So here's a keloid scar. Keloid scars are these raised scars that occur more commonly in people of color. For some reason, we don't really know why that is. I've never read a good explanation for that. but it does occur more oftenly more oftenly. I can't believe I just said that. I am not going to re-record this. I want to leave it because if you've made it this far in this lecture, you deserve to laugh. More oftenly. Oh my gosh. They occur more often in people of color. So they're raised, and the thing that's going wrong in these scars is exuberant collagen formation. And you just make way too much collagen, and you're missing that remodeling step where you cut it down to size. And these can just continue to grow, and even you can remove them, but of course the healing process is already abnormal, so you might just get another keloid scar. So it's a difficult thing. Here on the right, you can see a histology section of skin, and just to remind you, top is epidermis, the lower portion is dermis, and you can see all this thick pink stuff in here. This is all collagen, big bundles of pink collagen. This is way more than you should have in your skin if you're healing a wound. So this is a keloid scar. Here's the second wound healing abnormality where you've got too much of something going on. I think this is just such a great name. It just sounds like they're talking about something else. I just always laugh. I love Rick and Morty. I don't know if you guys watch this at all. New season is out. Super good. Anyway, made me think of Morty. So just this crazy term, proud flesh, whatever. It's called proud flesh because it looks really fleshy in a way that keloid scars don't. In keloid scars, you've got excess scar tissue, excess collagen, but here it's excess granulation tissue, which has this pink, bumpy, kind of flesh-like appearance to it. And you can see on the right, there's the three things that you normally see in granulation tissue. There's some little blood vessels in here. There's some fibroblasts, spindle-shaped cells, and there's some extracellular matrix in here too. So in this lesion, the patient just makes way too much granulation tissue, and it doesn't turn into a scar. The fibroblasts, for whatever reason, it just doesn't mature into that last phase where you make a nice scar and heal up the wound that way. So that's it for this lecture. I hope you guys watch Rick and Morty. It is one of the funniest shows I've ever seen, ever. It's so funny you can't even keep up with the jokes. Like I have to watch it and then pause it like every 2 seconds because something else happens. Anyway, love this show. So I hope this lecture makes sense to you guys. Let me know if you have any questions, and I'll post some summary lectures so you can go through this more quickly.